All right, good evening, everyone. Thank you so much for joining us. My name is Joanna, and I work with Performance Optimal Health, and we're proud to partner with ONS tonight to bring you this incredible content about diagnosing and managing hip pain. We are co-hosting this webinar with Dr. Manoli tonight. He is a hip preservation and joint replacement surgeon from ONS. Based out of our Greenwich, Wilton, and Stamford locations. So we're super excited to have him tonight. He's going to be talking about some incredible content tonight around hip pain, diagnosing, and managing. We also have Stash Rutkowski from Performance Optimal Health. He's a senior physical therapist based out of our Westport location, and he subspecializes in hip management. So together, we're bringing you two best-in-class teams to talk about this content and create some awareness around how clients can understand better diagnosing and managing their hip pain. So with further ado, we'll start off with Dr. Manoli. He's going to take us through some content for tonight.
All right, thank you so much for having me. I'm really excited to be here and talk about hip pain, a cause that's near and dear to my heart. I think it's important just when we talk about it to really understand what it is, where it comes from, and why we have it. You know, we could spend a lot of time talking about that, but it really is very nuanced, and it requires people with special expertise and an interest in the hip, like the people at Performance. And you know, I've certainly spent a lot of time training, trying to understand the hip and ways hips go wrong and ways to help them feel better in the least invasive way possible. So I'm excited to talk with you a little bit about that and some of the causes. So we're going to talk a little bit about hip pain and what it is, what causes it, how to keep your hips healthy, and how to avoid surgery by any means necessary. And then if we do need surgery, what surgery do we need and how do we figure that out? And there's a lot to unpack there, but we will definitely talk about it. So what is hip pain? So hip pain itself traditionally is pain located in your groin. So a lot of people think it's really this lateral outside area that is where your hip is, but the joint is kind of more inside of your groin, and that's generally where intra-articular pain from the joint is felt. But there's a lot of compensatory things going on and a lot of referred pain in the hip, and that's why it's so difficult. I have a lot of people that have pain all the way down their thigh, down to their knee. They have people that have pain in their glutes and in the back of their hip joint because there's some fibers of the hip capsule that are innervated in the back. And it can be very difficult to tell that apart from trochanteric bursitis pain, which is on the outside. Some people have more than one thing going on, and usually when it's been going on for a while, there's 3 to 4 different layers of things that are wrong. When hips hurt, everything gets thrown off because we compensate for it. Our backs hurt, you know, we start having pain in our abdominals, our knees hurt, everything starts to hurt. And a lot of times the driver of that is something inside of a hip joint. And sometimes it's difficult to unwind all of those things. And that's what we spend a lot of time thinking about and helping patients with. So the main causes of hip pain. So you can have a lot of things that go wrong, but in general, a lot of people, as you get older, the main thing going wrong is arthritis, and that can be painful and really limit your activities because the hip joint is deep inside. It's very hard to immobilize, and it's very hard to move past it when it starts getting inflamed. For people that are a little bit younger, reasons why people get arthritis in the first place, you know, there are other things that can happen, including hip instability when people have shallow hip sockets, like hip dysplasia. It's actually one of the main causes of hip arthritis in older age for people that aren't symptomatic when they're younger, but that can be a big problem and something that we work through a lot. Kind of the other end of the spectrum are people that have limited hip motion or hip impingement. A lot of times it's because the bones are bumping into each other. And over time, the main pain generator in the hip joint is a labral tear. And a labral tear is not necessarily a big thing. You can see there's a picture of it over here, and it can just be a small split in the gasket seal around the hip joint that creates a suction seal with the ball and socket. And that little tear usually is caused by something, some shape mismatch somewhere in the hip joint. But when it starts getting irritated, it can really be painful for patients. And and then you start having compensation, and all of a sudden 3 or 4 things are sore, all from one little small underlying cause. So it's a lot of our job here to unwind what the cause is so we can go through and fix all the problems. Sometimes people do have primary muscle tendon problems as the main driver of their hip pain. So this can be a little difficult to diagnose. Hip flexor pain, is the thing that's probably overdiagnosed, but can certainly happen. Hamstring and gluteal tendon problems are certainly an issue. And as time goes on, I'm seeing more and more gluteal tendon tears that are symptomatic in people, and certainly something you need to look out for, but can be difficult to diagnose. And then for other causes, there can be things that masquerade as hip pain, whether it's a pinched nerve in your back, or for a patient I saw earlier this morning, they had an ovarian cyst that was pinching nerves, likely causing some aspect of their hip pain. So it can get very tricky and confusing. That's why you need people who specialize in and have an interest in the hip, because it's not always simple. Now, if you do have hip pain, the best way to keep your hip healthy is to figure out what's wrong and get a diagnosis. Sometimes that can be the hardest part. Some people have a little bit of arthritis, but the most symptomatic thing is their muscular compensation for the arthritis. So you really need to be able to unwind and kind of understand what exactly is going on with the hip joint. The anterior dominant hip syndrome is kind of the most common thing that I see as a muscular compensation, something we'll probably talk about when we talk a little bit more about the therapy. But a lot of us spend a lot of time seated. We're not really engaging our glutes and our back and our core and all these muscles we know we should be working on, but are very hard to actually do in practice. So a lot of people will come to me with pain from compensation. The front of their hip joint, the tensor fasciae lata muscle and the hip flexors in the front are all tight, and the muscles in the back are not really all that strong. And the important thing is to try to get that muscle imbalance corrected. And generally, if the hip joint works better, regardless of what your problem is, it will feel better. And that's really, really important. But it's not simple. It's not an easy thing to do. I mean, you can't just go and do any exercise. If you're at the gym and you're squatting and doing some leg exercises, a lot of the times you won't really be doing the correct thing, and small differences in form make a huge difference. And when I see people, I try and personalize their physical therapy prescription or their exercise regimen to their specific things. Some people have different issues with their hip joints, and it really needs to be personalized. We spend a lot of time thinking and doing exercises like these, which are certainly not the normal ones you're going to be doing at a gym. But beyond that, before we start thinking about trying to rehab your hip joint, a lot of what we do on the medical side before, we talk about strengthening, rehab, and making your hip work better is trying to reduce pain and inflammation. And I really do think that is a requisite thing that we need to do prior to getting it rehabbed. There's a lot of patients I see that are in a lot of pain. And what I've learned is that when patients' muscles hurt and their hip joints hurt and they're inflamed, they can't really rehab and they can't get stronger and fix some of the underlying muscle imbalances that they have because it's too painful for their muscles to work right. So we talk about certain things. So we try to bring down inflammation the easiest way possible. Sometimes we do ice and massage and some manual therapy. We'll talk about over-the-counter NSAIDs, and a lot of times I'm writing people prescription NSAIDs. I could probably talk an hour on anti-inflammatory medication, but it can be really helpful to reduce pain and inflammation so you stop compensating as much and are able to move a little bit more naturally. And that can make a huge difference. There are prescription ones that work better and are safer than the ones that are over the counter, but it's really, really important. It's dosed appropriately, and you're doing it for a short period of time at a high dose. And those are things you really do need to talk with the medical professional about. But kind of beyond that, some people aren't candidates for that, or it's not effective. And this is where I've gotten much more interested over time in doing intra-articular steroid injections or cortisone shots in the hip and around the hip in areas that are sore. And the main goal there is not to really be a Band-Aid on the problem. It's to temporarily buy people a window of time to fix specific muscle imbalances that we can identify to help them feel better with the hips that they have without having to do anything more aggressive like a surgery. And that can be really, really helpful if it's targeted to the person and their specific problem. So we do a lot of those in our office. That's something that I do on my own as well, and have been doing more and more over time. So my overall treatment philosophy for the hips is to do a thorough evaluation. It comes down to the basics. I want to listen to the patient. We need to evaluate every aspect of them. Most people have a hip joint problem, and sometimes that's hard to diagnose, but beyond that, you need to understand how they're compensating, other things that are wrong. People that have tight hips will generally offload those forces to other areas like their sacroiliac joint or their back. It's common. There's multiple things going on, all related to a primary problem. So we need to understand what that is. And then we look and see what can we fix easily. You might have hip arthritis, but if we can make your muscles work better and your hip work better, you will likely feel better, and we can hopefully avoid more invasive things. And that's probably the most important aspect of that. So when it comes to helping hips recover, I think about it in different ways. And really step one for me is to try to get the hip quiet things down, reduce pain and inflammation so we can rehab things appropriately. And this is true after surgery. And also if I see somebody who's trying to avoid surgery, we do the same things. We do activity restrictions, medication, possibly some targeted, thoughtful steroid injections to temporarily buy them time to fix some of the underlying problems that are easy to fix. At that point, we usually get them into physical therapy, like the wonderful people at Performance, and work on, starting things from the ground up, trying to get their muscles working as a team and coordinating. I have people whose glute muscles, probably the most important muscles in the hip, are not firing well when I see them because their hip hurts. After I do a steroid injection in their hip joint, their hip is numb within about 5 minutes after I inject. And I'll usually re-examine people. And I notice that all of a sudden the muscles that weren't working because of pain, all of a sudden are much, much stronger. And that really is a great window of opportunity to get everything working well as a team. And then once things are working well, we can get it stronger and then start working on sport-specific, activity-specific movements that are important to the patient. People love pickleball. A lot of people like to swim. We have a lot of rowers that we see with hip problems. And all of these require a different, more nuanced approach. That's really important to have somebody who's engaged and a professional when it comes to rehabbing hips. So speaking of rehabbing hips, I will turn it over before we bounce back and talk a little bit about what we do when the easy stuff doesn't work.
Thanks, Joanna, for the introduction. Thanks to Dr. Manoli for giving us a better understanding of hip pain and its causes. I'm going to jump right into the evaluation and my role in your journey of optimal health. You either come to physical therapy with the script, and when we work with Dr. Manoli, it's great because a lot of times it is very specific. Hip pain secondary to arthritis or femoral acetabular impingement, but oftentimes it's not as easy, and we get a generic script with just something that states hip pain, evaluate and treat. And there's other times that we will see you with by way of direct access, which means I'm going to be the first medical practitioner that you will see. Regardless of the pathway, my process is the same, a comprehensive, detailed evaluation. It starts with a thorough history, which is imperative to fully understand what is going on with your hip and how it will be best managed. Listening to you as a patient is the key and the cornerstone to a correct diagnosis and a successful journey. Oftentimes, there's a need for me to ask follow-up questions that will further assist in understanding the specific problem that's going on with your hip. So a few of these questions are as follows. Mechanism of injury. Was this from trauma or insidious onset with gradual progression? Pain, the location. Is it in the front, which is a lot of times what we see with these impingement type patients? Is it in the back or buttock area where we have to differentiate if it's coming from your SI joint, from your hip, or the lumbar spine? Is it more in the groin or inner thigh, which is more associated with hip osteoarthritis? Or is it on the outside of your hip where we see a lot more tendonitis and bursitis? Timing. Is it worse in the morning, which we typically see with more of our arthritic conditions, or are we seeing it more at night? Is it constant, or does pain come and go? Is your pain more associated with activity, or do you typically have it at rest when sitting? These are all important questions that I need to filter out to figure out what the problem is. Pain can be sharp, dull, achy, or like Dr. Manoli said, it can radiate from the hip in towards the knee. Some aggravating factors that we're going to want to think about. Does sitting bring on your pain? Is it more with walking or twisting activities such as sport or getting in and out of a car, which I hear often? Do you get it when you roll over in bed or you lie on your side? And what about some alleviating factors? Maybe ice, massage, exercise. Oftentimes I hear people say, I put my thumb in my hip and it feels better. So these are all things that will help me diagnose and then help in the treatment down the road. At Performance, we incorporate the 4 pillars of optimal health: exercise, recovery, nutrition, and stress into your care. This helps to enhance and expedite your path to success. My job is to assess each of these pillars and to make recommendations to enhance your recovery. When we talk about exercise, I want to talk about first the type of exercise that you're doing. Is it more cardiovascular? Is it more strength training? If it's strength training, what type of strength training are you doing? The dosage, frequency, intensity, duration, these are all going to be important. Are you overdoing it or are you underdoing it? Is your form proper? Or are you doing things that are correct? You're doing exercises that are appropriate, but you're doing them incorrectly. This is going to be important for me to wean out these problems to see how I can best treat you. The American Heart Association recommends 150 minutes of moderate exercise a week. Question that I pose to the audience is, are you getting that? Exercise can be helpful to your hip, but it also can be more problematic and painful if you're not doing it properly. Recovery. Sleep is the number one thing. It's free for all of us, and we should be getting between 7 to 9 hours of it. Sleep deprivation can affect your immune system. Sleep is one of the best tools for recovery. It fortifies every system in your body. It can boost your immune system, and it certainly can help with muscular repair, which is what we see a lot around the hip. Massage is another important aspect that we'll utilize. This will help recovery. It'll help reduce tissue tension around the hip, along with swelling reduction, which will improve mobility and also help in efficiency of the muscles to fire and the joints to move. And lastly, in recovery, we use a lot of cryotherapy in our offices. And this is clinically researched. This is a clinically researched modality which uses liquid nitrogen to enhance the recovery from injury or exercise. It decreases inflammation, and it ultimately improves your sleep as well. Nutrition. So again, this is the third pillar here. Proper nutrition can certainly promote growth of muscle and increase bone strength. It can also reduce inflammation, so you want to be eating the right foods. On the flip side, eating poorly can lead to weight gain. This increases stress to the joints of the hip, the soft tissues around the hip, and the muscles. And lastly, stress. With higher levels of stress, this can increase inflammation in the body. Question is, how do you manage your stress? This is an important aspect, as we all have some level of stress in our daily activity. All four play a role in your hip's health. By educating you on these, this will help to achieve your goals and result in a successful outcome. Finally, I'm going to talk about the musculoskeletal exam. This is kind of our bread and butter as sports physical therapists. We're going to observe you, look at how your posture is, assess muscle atrophy, limb asymmetries, look at your spinal alignment. Are there increased curvatures in certain areas? Is there some scoliosis that's going on that may affect your hip? And then we're going to look at how you walk. It's important. Are you compensating with certain movements? Or does your hip not allow the right motions to occur? So therefore you limp. Functional movements are going to be important for me to assess. Squatting, single leg standing, going up and down stairs. These are all things that I'll look at to see if there's any compensation going on for your hip pain. And then looking at your osteokinematics, or how your bones move, looking at both your mid back and your low back, as well as your knees, foot, and ankle. If you have injury or problems in other areas of your body, that can bring on hip pain. So we want to look at the full kinetic chain to make sure that there's no issues going on somewhere else. Risk factors, certain things that we want to look at with our femoroacetabular impingement patients. These patients have anatomical abnormalities with the fit of the ball in the socket of the hip joint. So rotational sports are going to be sometimes problematic, sitting in lower chairs, activities that require repetitive hip flexion or hip movements going upward. These are all going to be risk factors for this type of patient population. For osteoarthritis, obesity, of course, is a number one factor here. Your occupation, heavy laborers are going to have increased risk, as well as increased physical activity. And then, like Dr. Manoli said, dysplasia, where we have lack of coverage of the hip, more of a loosening of the hip. Females are going to have an increased risk, firstborn, and family history. Moving on to causes or etiology of hip pain. These are certain factors that are going to bring on hip pain. So bony alignment, we want to look at the whole kinetic chain, like I stated, from your foot all the way up through your spine. If there's areas affected in one joint, that can bring on hip pain, muscle imbalances, timing, control, fatigue, or weakness in the muscle will have a great effect on your hip musculature. Strength deficits in and around the hip or in through the thigh certainly may bring on hip pain. Any sort of decreased mobility around the hip or flexibility will also put increased stress to the joint structure and the soft tissues around the joint. Next, I'm going to break out the hip into 4 main buckets that I typically see. The first is going to be femoroacetabular impingement. Pain is typically in the front of the hip or in through the groin area. It can be sharp or dull. Oftentimes, people are restricted in their hip motion. Locking, clicking, and catching can be seen or heard. These patients typically complain a lot in terms of sitting when the seat is low, and we'll talk about that a little bit. Functionally, they have difficulty with uphill walking, pain with rotational activities, twisting, getting in or out of cars is a big thing that we see in the clinic, as well as sport activity. The next one is going to be dysplasia, and we can see here you have the healthy hip, and on the opposite side we have the unhealthy hip or the dysplastic hip, where there's less coverage. These patients typically complain of pain in the front of the hip or through the groin. It's usually worse with activity and toward the end of the day because of the fatigue that goes on with the muscles. Therefore, the joint gets loaded more. These patients often feel tight and want to stretch, although stretching could be one of the worst things and promote more pain and limitation in your hip. These hips are usually more unstable, and you see a lot of movement. And one of the major complaints is limping and pain with walking. Next, osteoarthritis of the hip, where we have a breakdown of the articular cartilage. These patients typically will complain of pain in the groin, outer thigh, buttock, and also can radiate to the knee. We see typically more morning pain and pain later on in the day when you fatigue, flares with more vigorous activity. You may see limping with a decreased stride, and standing can be problematic, especially with increased duration. You'll often see reduced range of motion with difficulty bending over to tie your shoes and put on socks. That's a major complaint I often hear. You may see some seen here audible clicking, catching, and snapping, and more often than not, you're going to see weakness in and around the hip. And then on the outside of the hip, you're going to see some trochanteric bursitis or tendonitis. This can be sharp or dull depending on the acuity of it or how recent the symptoms are. Usually worsens with prolonged standing and walking, and with stair climbing. It's usually worse at night, especially when you roll onto your hip. That's a major complaint of this population, is pain with lying on your side. It's associated with some decreased activity. Oftentimes you'll see some swelling and warmth on the outside of the hip. No matter which of these hip conditions that you may have, you may need to change some of your daily activity. And when we talk about that, we're talking about avoiding certain standing postures. The one you can see here, we're loading the front of the hip more here. And like Dr. Manoli said, we can load the front of the hip. That may stretch out the front structures, shorten the back structures, and give you some weakness in through the gluteals. So that's an area we're going to want to focus in on. To the right here, sitting in excessive hip flexion here, where we see the chest to thigh angle. We want that to be greater than 90 degrees. When we see a decrease in that angle, we can see more compression through the front of the hip, causing more pain. And then sleeping positions. Certainly with our impingement patients, we're bringing the hip up into higher degrees of flexion angle here and bringing it inward more. That's going to cause a little bit more compression into the hip and increase the chance of having some pain. So it's important in our daily activities to modify some of these things so that the appropriate treatment can be rendered and it can address the hip issues at hand. Treatment of the hip. Well, no two hips are the same. We can see here, this woman has incredible amount of motion, whereas this woman has less motion and more stiff. So Treatment has to be individualized and based on pathology and their presentation in the clinic. Most important thing that I can do is educate my patients. I think over my 20+ years, if there's one thing that's the most important, I think that I've gained is that statement right there. That goes a long way in terms of really helping the patient, educating them on what exercise they need to be doing, what the pathology is at hand. So kind of to piggyback what Dr. Manoli said, I think pain reduction is paramount. When they see him in the clinic, if he can calm them down, it's great because it makes our job a lot easier. If they're flared up, then our job is also to help with that pain reduction. We're using some of the modalities that I talked about. Massage, cryotherapy are going to be big things that we use in the clinic. And also rest, modification of activity. People might be walking too much or doing too much activity or sport activity. Those are things that we're going to have to modify, slowly bring them back and get them back up to speed. Pain reduction this will be present in most all hip conditions and certainly all the ones that we've talked about tonight. Mobility, flexibility. If the joint is stiff, we need to work to mobilize it and get it moving more freely. You can see here a picture. Here, this is more of your arthritic hip where I'm trying to mobilize the hip, get a little bit more gentle motion through, which will give some pain relief. The top picture here is an active release therapy technique, which we're working on some of the front muscles of the hip, and that's going to help make the muscles move more freely and allow you to have a better stride when you're walking and decrease your pain with that walking cycle. If the muscles are tight, they need to be stretched. This is based on muscle length and not on what you feel as a patient. Strength, if we see muscle weakness and pain, it's likely going to be, and swelling, that's going to most likely lead to muscle inhibition. And then strengthening is going to be really important for this population. If pain and inflammation continue to occur, we need to really modify and adjust treatment so that we can reactivate their muscles, to unload the hip, decrease the stresses to the soft tissue structures around the hip. Sometimes people come in and they're actually strong, but they need to re-educate the muscles to work more properly and efficiently. So it's not always a weakness issue, but more how do we re-educate the muscles to work properly and more efficiently. In our dysplastic hip, where we have less coverage, those are patients that are going to utilize their hip muscles more, especially in the front. Oftentimes they can overwork those muscles, so they're inflamed and irritated. So what my job as a therapist is to re-educate them how to work more efficiently and properly. Kind of just getting back to our 4 pillars, this kind of goes in and out of my treatment throughout each daily session, and as you complete your process through the journey. Many of these hip pathologies are lifelong and need to be managed conservatively, and each pillar will play an important role in optimizing the journey. Each of the pillars can greatly enhance and expedite the path to success. You need to ensure a healthy lifestyle of exercise. Again, I often utilize our trainers, our personal trainers and our Pilates instructors to augment your fitness there, especially when we get into later stages when you're feeling good. When we talk about proper recovery, I'm often utilizing our massage therapists to assist in soft tissue mobilization, mobility, and lengthening of muscles to make sure the muscles are firing efficiently. Nutrition, this can aid in building muscle strength and also bone strength. Our dietitians are available for detailed plans if this is warranted, if I feel this is warranted. And then stress, we need to reduce the stress levels. If we don't reduce this, inflammation in your body is going to increase. So meditation, deep breathing exercises, these are things that I'll often work with patients so that they know the right steps to promote better health. In summary, I think the most important thing is pain reduction. If, like Dr. Manoli said, if people are in pain, they're not going to be able to fire their muscles properly. So we want to first reduce pain. And a big part of that is modification of activity and educate. If we have this inflammation, it's going to lead to muscle inhibition, which is going to lead to weakness. So we need to strengthen and re-educate the muscles. We want to make sure that a muscle, if it feels tight, that doesn't mean we need to stretch it. It's more important to look at the length. And we want to always keep in mind the 4 pillars. Each of the pillars plays a significant role in the health journey, and using these tools and services will help expedite your recovery and lead you to a path of success. Thank you.
All right, thank you. I thought that was incredible. It's really, especially the part about education. And I think it's incredible when patients come back and feel that they're more engaged in their overall treatment, look at things from a more holistic level, and really understand their hip problem. And I feel like if people are educated and they understand the pathology and what's going on and are able to adjust and change their activities as they go, it really helps them feel better, not just in the short term, but in the long term, they have a better understanding and they're able to stop problems that we've quieted down once from coming back prior to them becoming a bigger issue. I think that's really, really big and important. So now to talk a little bit about what happens if the easy stuff doesn't work. So why do we need surgery? And I think one reason why we think about it is some people get stuck at that first step, pain and inflammation, and we can't quiet down their hip enough to get it rehabbed and working better. If you're stuck there and you can never get out of that cycle, the problem is too big to overcome. That's one reason why we think about it. Or we're able to get people through a rehab course, and then we look at where they are and what they can and can't do. And if there's residual symptoms, sometimes there's a risk and benefit discussion about how much better do we think we can get you. There's some people just have, you think about a foundation, your hip problem underlying is really the foundation to your house. And the muscle strength, function, rehab, all of that is the important stuff. But if the foundation has a problem, you can't build a good house on a bad foundation. And sometimes the foundational problem is just not good enough to rehab your way out of. And we need to intervene to create a better foundation that you can then build a better house on that will last a long time. And I think about it like that. And it's an interesting way to think about it, but it really is true and why we do what we do. So when we talk about surgeries for hips, some of the stuff we think about, I've certainly heard about hip replacement surgeries. The techniques have really improved. Certainly the outcomes have too. We expect the implants we're putting in now, so long as there's not an early complication, which is unlikely, to last at least 30 years, probably a lot longer. For most people, they're going to their implants will outlive them. People are really happy with them and they work really, really well. The techniques are better than they've ever been. Incisions are smaller. People in particular with some of the anterior approach hip replacements, which I do, and I think a lot of people are doing now, they almost feel too good. And we run into problems. I'm sure, at Performance, you see this too, where these people have a new joint, but their muscles aren't quite ready and they're still healing, but they feel good and they don't have the pain. So sometimes we spend time trying to slow them down, actually. Long-term restrictions, there really aren't any. People feel great and the results are good. But they're not for everybody. I've done advanced training in hip replacements and also in hip saving surgeries, so kind of comprehensive hip problems. And I love hip replacements, but there's problems. They work really well for most people, but if you have a problem, it's generally a really, really big deal. If you have an infection, it can be catastrophic, especially at a young age. High impact activities are not best. And the thing about hip replacements is I've always been surprised that they don't have the range of motion that you would expect. Sometimes they get a little stiffer than your native hip and for reasons that are unclear, but that's just the case. And the muscles don't always work as well as they would in your native hip. Most people are happy, but your hip is the best hip you'll ever have. And we try to make it work well. And if we have to do something, we try to save it. I do a lot of hip things in young patients, and some people have bad problems at a very young age. And, sometimes we do hip replacements in young people too, even people in their 20s and 30s. But these concepts are true for people that are older too. If you have a problem with a hip replacement, it's a very big deal, and the problems can snowball. And then, we kind of have data out to 30 years on some of these, but we don't know how long people will live. People will live a long time, and we don't always know what will happen in the near distant future. So in general, if we can save hips, we like to try to, and they tend to work better when all said and done. So hip preservation is a unique field. It's really about the evaluation and treatment of hip pain before arthritis, which is why I love talking about hip muscles and rehab and recovery, because it's very involved in that field. There's a lot of surgeries and things we can do to help your hip work better without doing a full hip replacement. And they may actually put that off. Even if you are to have one, we can buy you time so that you can enjoy the hips you have for longer. It combines a lot of different techniques and specialties, and the diagnosis of a lot of these problems is really complex. The rehab's complex, and the treatment surgically is complex. Still really limited availability. Some of these surgeries, there's only 1 to 2 people in a state who are doing some of these things. And the reason it's not more well known is because it's incredibly hard. It takes a really long time to do. And it's not always simple. We need to identify the underlying hip problem, really understand what's wrong. And if we understand what it is, and we have the right equipment, skills, and people and expertise to treat the problem, we can help save hip joints without replacing them. And it really is incredible. But we really need advanced technology, and we need good teams to rehab people who understand the hip joint and how to get people feeling better without making other things inflamed in the process. And the reality is that diagnosis drives management. That's why we've been talking about it so much. Is the problem from your hip joint? We start there, and it's not always the case. And sometimes we spend a lot of time thinking about that specific problem. I've probably done 3 or 4 diagnostic hip injections so far in the afternoon today, just to people where we're not sure if the pain's really from their hip or if it's from their back. And we have the amazing ability to target different things that we think are causing pain to try to identify the root source of the problem, to make sure that we're treating the right thing before we do more interventional management. And honestly, I think it's really helpful to know what's wrong even before we do our conservative management. I wouldn't want to send somebody for physical therapy unless I knew what was wrong and what I wanted to improve. So I think it's really important that you have a diagnosis if you have hip pain, and see somebody who specializes in it so you can really understand what the problem is. Hip impingement, like we talked about, is a huge problem. I see it all the time. Sometimes these problems linger for all of patients' lives. They can create arthritis later on, but a lot of them are symptomatic early on, and and I see it in everybody from 12 years old all the way up to 80 years old. And it really is incredible. Having tight hip joints and impingement offloads forces elsewhere. And that's maybe one of the big things. People with hip impingement have SI joint inflammation, and they've always been told they have tight hips. They sit differently. It can be painful to sit for too long. They can be uncomfortable. They have low back pain. There's just so many things because these forces get offloaded to other places. And I've really come to have an appreciation for that. Hip instability is a whole nother topic, one near and dear to my heart, and we're learning more and more about it. It's incredibly complex. You have to look at so many different parts of a person to really understand it. But if we do, we can do a lot to make people better, regardless of age with this, and help avoid or put off hip replacement surgery until later. Femoral torsion is something I've been thinking a lot about lately, and there's a lot of variability in the twist of people's thigh bones. These are 2 femurs. And in general, you see the knee joint at the end and the ball at the top. So these are 2 very different twists on this thigh bone. Some people's hip, the ball of the ball and socket points more forward, and they usually compensate by rolling their thigh in and in-toeing. You've probably seen people walk like that with their toes pointed in, and that's why, because they try to keep their hip in the middle and they roll their thigh in. And the variability really is incredible. I see a difference of 40 to 50 degrees between people that just walk in the door, and that totally affects the rehab. It affects all the muscles. It affects everything about the hip, in the back, in the pelvis. So we spend a lot of time thinking about this too, and these are things we need to understand to know what's wrong. One of the more common surgeries I do is hip arthroscopy. If we find something wrong in a hip joint and we have tried to get you past it, we've tried to rehab your muscles, we've tried to get you over a labral tear or an impingement problem, and we're not able to, or we can, but you're just not happy with the level of symptoms, we can sometimes intervene, go inside, recontour everything, fix the labrum through very small incisions on the side of the hip, and then get you rehabbed and push you past the place you were stuck at before. It really is incredible. Our techniques have improved. The systems that we use now are essentially an image-guided system where we're able to measure all the angles in surgery to make sure that we recontour things perfectly within a preoperative plan. Our rehab has gotten so much better, and that's what's really been the best part, is we understand how to rehab people and get them stronger and get them back to activities. People who have the surgery go back to playing professional sports. It's really incredible, and we've been able to manage a lot of the associated post-surgical pain much better, and it's much safer than it's ever been. For people that have shallow hip sockets, sometimes they can be treated with hip arthroscopy, but sometimes it's a little bit more than that. And for these people, sometimes they need a bigger surgery called a periacetabular osteotomy, or a PAO. And these surgeries sound like they're big, but it essentially involves taking the hip socket that you have that's shallow, making some very carefully controlled cuts and reorienting it so it covers more of the ball. We generally do this in younger people that have hip pain that doesn't respond, or have failed hip arthroscopy and maybe had the wrong surgery in other places. This surgery works really, really well and really is incredible, and is something that, there's only usually 1 to 2 people doing it in a state. It's something that we do here, and something at Performance they have a lot of experience rehabbing people through, and it's a very helpful surgery for people that need it, but you don't know that you need it until you get the right diagnosis. There's one of the patients that I've done it for, very shallow socket, getting reoriented, fixed in place with screws, and now that ball is more covered by the socket. It heals well, and people go back to playing very high level athletics after that surgery. Most people have no pain after. It's really an incredible thing once people are healed. And for tendons, as we get older, the tendons don't always cooperate, and there can be chronic inflammation, partial thickness tears. We try to offload, rebalance. Sometimes we just can't get over the inflammation and pain from some of these tendon tears. So we've been able to fix a lot of these through camera surgery, which is a newer thing that we're doing now. We're able to go inside, clean these up, get them to heal better. We have these new biologic patches we can put on tendon tears to help them heal faster. You can see that picture on the bottom right. All these through less invasive surgeries than ever before. But the most important thing is understanding what's wrong, trying to get the right diagnosis, making sure we've rehabbed it appropriately. And then if we do need to do something, making sure we rehab our way out of it, right? We're able to kind of deal with complications of these from people who've had other surgeries and still don't feel good. We've really come a long way. The important thing, like I said, is to understand what's wrong, really work hard, be engaged in your treatment, and then just know that there are options for people other than hip replacement, so long as we understand what it is. And even with surgery, we need a lot of work on the rehab side to make the hip work better. But if if you're really engaged and work at it, you can get back to doing some incredible things regardless of what hip problem you have. So I guess I'll leave it there.
Excellent. Dr. Manoli and Stash, thank you so much for presenting that content. I know we still have some individuals still on the call, which is great. If anyone has any questions, we'll host our Q&A now. If you do have an opportunity to post something in the Q&A chat, we can see it on our end, and we'd be happy to answer your questions. We do have a recording of this, and we plan to share it out with those that attended tonight, as well as those that may have missed us. So please feel free to share this with anyone that you might think that would find this information valuable. So we'll go ahead and just give a few minutes to see if any questions pop up before we end the night. Excellent. We got a lovely question coming in, and I think I'm just going to read it out loud so that everyone can hear the question, and for specifically Stash and Dr. Manoli. So a question just came in. Could you discuss your favorite prehab exercises recommended prior to a THA, a total hip replacement, I think? And could you discuss the merits of anterior versus posterior THA surgery? That's a great question.
Sure, I'll jump in first with the first one. And, my favorite prehab exercise, it's going to really depend on how you present. That's most important because you could have weakness in all areas of the hip. Specifically, what I see most of the time is your glutes, and that would be your glute medius on the outside of your hip. That's the one I would say that I see the most weakness in, but you might be inflamed through the front of your hip, and we need to really calm that down more so than anything, because that muscle kicks in when you have an arthritic hip. So there are a lot of muscles and exercise that I would do, but it really depends on your level of pain, how irritated you are. When patients go in for surgery, I see some that can hardly walk 10 feet, and then I have some that can walk 2 miles. So it's kind of a challenging question, but I would say I would key in on the outside muscle group. And depending on how debilitated you are, I would start off with something very easy with a side leg lift, or I might get you standing and do some sort of band walk to really activate that muscle.
I would completely agree with those thoughts there. I think the most common things I see as well are also inflammation, tightness in the front, and weakness in the glute medius, and making sure that, you know, your glutes are able to fire going into surgery would be great. You may not be able to get them much stronger if your hip is really stiff. So some people really battle stiffness. And when the hip is stiff, it's really hard to get the motion that you need to engage the muscles, which is one of the reasons why I think people need hip replacement in the first place. So, you know, we'll be able to strengthen them more afterwards, but really calming down inflammation, I think, is huge. If you have soreness in the front of your hip and your hip flexors and you're going in for a surgery, that problem's not going to fix itself necessarily on its own. So the more loose and you know, with the lowest amount of inflammation you go in with, that's really the big thing. If we can get a little strong going into it, I think that's helpful. Anterior versus posterior. So they're both types of ways of doing hip replacements. Either one can be less invasive. It's not necessarily less invasive, only anterior versus posterior. There's different ways of doing them. I do both of them in different circumstances, but tend to prefer anterior for the most part. I think I can make my incision a little bit smaller. I think the risk of dislocation is a little bit less. The best part for me is I get to use X-ray during surgery very easily. So I make sure the leg lengths are absolutely perfect, that I'm very happy with everything, and that there's no surprises. It's more consistent. And I think it's easier. And there's good data to support a little bit faster recovery on the front end. But in long term, they are the same. It's important to go to somebody who does a lot of them, is engaged and is interested in them. But if I don't think one is necessarily right or wrong, but if I had to have one, I would have it anterior. And that's what I tend to do for most patients.
And I would second that. I think on the rehab side, if I had to choose, I'd much rather do an anterior. Again, in the end, they both do very well. It's one of the best surgeries out there, but you can be a little bit more active and move forward, be a little bit faster in your recovery and rehab with the anterior approach. There's less, there's more sparing of the muscle, so you're disturbing less of the musculature.
Excellent. That was really, really comprehensive. And I might have misspoke. THA, what does that stand for?
Total hip arthroplasty.
Got it. Excellent. Perfect. We do have another question, actually. And so I'm going to read this one aloud as well. Is there a need to stop working out if there is a minor problem, or is it better to keep it up, to keep up blood flow? This person reports that they often feel better when and right after they work out, running, etc. And so they're curious to know sort of how to navigate that.
A very good question. And sometimes there is a need to stop working out. That doesn't mean that you're going to lose everything. We may just need to modify certain things. You might be doing too much pounding and impact with the running based on how your strength is. So what I would say is you need a really good assessment to see how your hip is reacting, or how your hip is presents. And then how you react. Oftentimes, yeah, there's when we work out, we increase blood flow to the area, we increase our endorphins. So there's a lot of good things that come from exercise. So it's a little bit of a kind of a cloudy question, but you don't want to exercise into pain is, I guess, the most important thing.
Yeah, I agree, but I do think people's hips generally are more inflamed than what they feel a lot of times. You really do need that objective assessment, have somebody you're partnered with, either therapist or physician, to try and take a look and to bounce some of these questions off of. You don't want to increase the inflammation cycle and get into a hole that you can't dig yourself out of, but certainly some minor pain when doing stuff is expected, so long as it doesn't perpetuate a cycle, is that thing. But it's good to have a professional evaluate you to really know.
Excellent. We've got another question. These are really, really excellent questions. And I am going to read it aloud again for the group. Of course, keeping the individual's name anonymous. So here we've got an individual that had a total hip replacement 6 years ago, and after 3 years, it has dislocated 3 times. I'm sure that both Stash and Dr. Manoli, you've probably heard stories and have had patients with a similar issue. There was a revision surgery, which put a cup-like structure over the joint, and things have been pretty good. The question is, now my other hip is giving me pain. I went to ONUS for an exam, and they didn't offer any alternative except when I was ready for surgery. So I do have bone on bone and some spurs. Would I possibly be eligible for injections? Great question.
So in general, when hip joints have bone on bone changes, it's really hard to get things much better. I'm a huge believer. So in general, if somebody has arthritis, it's not a surgery or nothing thing. A lot of times people are in the middle, and there's certain cases where I'm a huge fan of doing an approach to most things with the hip, where if things are really hurting and you have reasonable mobility and you want to have peace of mind that you really need the surgery, which is really, I think, what the question is. Some people really don't want it. They've had bad experiences. They've heard bad things. And if you need surgery, they're willing to do it, but they want to know that they really need it. Well, one thing you can always try is a combination of 2 things. I'm a big fan for some people of intra-articular injections in their hip joint with cortisone, really reset the joint, bring down pain and inflammation for a period of up to 2 months, and use that as a tool to really get your hip stronger and fix muscle imbalances that you have that we can identify that we think we can make better. Some people have imbalances when you're bone on bone that you can't make better. Sometimes you don't have enough motion to engage your muscles because your hip doesn't move. But if there's a chance, that's something that you can do to get to a better place. And for some people, that does make a difference and they're okay for a while. And then if it doesn't work, well, then you have prehabbed, you've gotten stronger, you're as strong as you can be going into it, and you have peace of mind that surgery is actually something you need because you've tried everything. So it really depends on the person, but it's not always so simple as just bone on bone needs surgery. You really need to talk to the person, see what they need emotionally, see what they've been through, and then see what other options there are. There's always other options other than just surgery. So, sometimes it's nice to get another opinion.
Excellent. Very good. We'll give it another minute or so, and then we might end up wrapping tonight. Again, like I said, we'll have the recording for those who would like to revisit some of the slides and the content, as well as share with family or friends. If it's okay, I know Stash, you're super open to this. Dr. Manoli, if you have a general email, or if you'd like us to share your contact with those that have answered or have asked questions tonight, to continue that conversation. Of course, I know from both parties, a full examination is always best before providing any specific medical advice. But that said, I know from performance, we're always up for providing education and guidance. And I know ONS and Dr. Manoli, you're of that party as well. So this was really great. Thank you so much.
Thank you. I appreciate it. It was a great conversation.
Excellent. Well, this concludes our event for tonight. Thank you for those who were able to tune in. For those that asked questions, these were wonderful. And we look forward to seeing you at the next one in the next month. We'll be sending some communications out about that. Thank you again.
Thanks, Dr. Manoli.
Thank you.